Vestibular disturbance is a significant issue globally, with 80% of people aged over 65 years experiencing dizziness. Individuals who have vestibular impairment generally have problems with gaze and motion stability, as well as balance and postural control dysfunction. Vestibular rehabilitation is an evidence based approach to managing these dizziness, vertigo, motion sensitivity, balance, and postural control issues that occur due to vestibular dysfunction. A very wonderful good afternoon to all. I hope all the attendees present, teachers, and a significant speaker for the day, Dr. Doa S. L. Sharif Ma'am, are in their best spirits. Myself, Sanya Chaudhary, a final year student from Banarsi Das Chandiwala Institute of Physiotherapy, would like to welcome you all to today's webinar on Introduction to Vestibular Rehabilitation. To throw more light on the topic, I would like to introduce our eminent speaker for the day, Dr. Doa S. L. Sharif Ma'am. A very warm welcome to you, ma'am. Dr. Doa S. El Sharif, Vestibular Rehabilitation Specialist, Consultant, and Certified Clinical Research Coordinator from King Abdullah International Research Center. Education. Ma'am has completed her bachelor's degree of physical therapy in 2011 from King Abdullah Aziz University, Jeddah, Kingdom of Saudi Arabia. Has done clinical research coordinator in 2012 from King Abdullah International Medical Research Center, Riyadh, Kingdom of Saudi Arabia. Ma'am has gained her master's degree in rehabilitation science in 2014 from University of Pittsburgh, United States. Ma'am has gained her Doctor of Philosophy degree in Neuromuscular Science in 2021 from Temple University, Philadelphia, United States. The dissertation title was An Examination of the Potential for Autonomic Nervous System Responses and Postural Sway to serve as indicators of visual vestibular mismatch under the mentorship of Dr. Emily Keshner. Certifications. The certificates that goes to her name are Advanced Vestibular Physical Therapist Certification from University of Pittsburgh, USA, Certificate in Teaching in Higher Education from Temple University, Philadelphia, USA, and last but not the least, Certificate of Achievement in Vestibular Rehabilitation, a competency-based course co-sponsored by Emory University and the American Physical Therapy Association, Atlanta, Georgia, USA. Work history. From 2012 to 2013, Ma'am has worked as a clinical observer in Pleasant Park Nursing Facility, Philadelphia. From 2014 to 2015, as an observership supervised by Dr. Susan Whiteley, University of Pittsburgh Medical Center, Eye and Ear Institute, Pittsburgh. From 2014 to 2015, she has also worked as a teaching assistant in University of Pittsburgh, and from 2016 to 2019 as a student of clinical researcher at Temple University Medical Center, Otolaryngology Clinic, Philadelphia. From 2019 to 2020 as student clinical researcher at University of Pennsylvania Hospital, Otolaryngology Clinic at Philadelphia. From 2020 to 2021 as a clinical researcher at Hafir Al-Bekin Central Hospital, Hafir Al-Bekin, Saudi Arabia, and from 2016 to 2021 as a research assistant at Temple University of Philadelphia. Courses. Ma'am has been enrolled in various courses such as Diagnosis and Management of Dizziness, Vestibular Rehabilitation, an advanced course and update, Foundation of Vestibular Rehabilitation, the Vestibular System and Children and update, Taping Concept, Theory and Practical Training for Medical Taping course, completion of 4 days of upper and lower quarter neurodynamic solution course, clinical neurodynamic total practice and lecture, last but not the least, radiology for non-radiologists. Ma'am is an eminent member of Saudi Physical Therapy Association since 2009, Jeddah Physio Club since 2009, and of Vestibular Disorder Association since 2016. For the sake of personal development, she has gained data capture training for NGHA research coordinators, good clinical practice at ICA GCP for NGHA investigators, and a quantum touch level workshop. Her publications are following: electrodermal and postural responses. Participants kindly the effects of visual context on visual vestibular mismatch revealed by electrodermal and postural response measures, an examination of the potential for autonomic nervous system responses and postural sway to serve as indicators of visual vestibular mismatch. Prevalence of restless leg syndrome and physical therapy association in Saudi population. Abstracts from Gulf Thoracic Conference in Dubai 2011. Professional presentations, 6th Medical East Vertigo and Hearing Disorders Conference. The topic of the conference was vestibular migraine and an examination of the potential for autonomic nervous system responses and postural sway to serve as indicators of vestibular migraine. At International Online Vestibular Diploma, the topic was visual vestibular mismatch, seeing beyond the big picture. Comprehensive vestibular system journey. Topic was dizziness in the emergency department. The dizziness differential diagnosis and management. Topic was dizziness, one word of different concepts. Many honor awards grants received by her are in 2011-2012, she has received scholarship in Clinical Research Coordinator Training Program from King Abdullah University. In 2019, at International Medical Research Center, Temple University College of Public Health Research Day, Dean's Award for Research. In 2019, the recognition of oral presentation at Vestibular Oriented Research Meeting, the US Naval Medical Research Unit, Dayton, OH. In 2019, Temple University, the CPS Visionary Research Fund worth $5,000. In 2020, the Graduate Board Fellowship Committee of Temple Doctoral Dissertation Completion Grant worth $11,000. Thank you. Thanks a lot, ma'am, for tuning with us. Now I request you to kindly take over the session and enlighten us. ये नहीं चल रहा. Ma'am, kindly take over the session and enlighten us.
Hello, everyone. I need you to enable me to share my screen, please.
Ma'am, you can share your screen.
I can't. It's
Yes, ma'am.
disabled. So, okay, now I can. Thank you.
You're most welcome.
Okay. So, hello everyone, and sorry about what was happening in the Zoom meeting. I would just like to ask everyone to be muted till the end of the lecture. And if you have any question, please write it down and make sure to ask it either in the chat or ask me directly after the end of the lecture. So they introduced me. My name is Doa. I'm doing vestibular rehabilitation therapy. So I will start with a short story. So as I was told by Dr. Shiduri, you were introduced to anatomy, but you were not introduced to vestibular rehabilitation. And this is exactly what happened to me when I finished my bachelor degree. I had no idea about vestibular rehabilitation. Actually, even the anatomy, I did not know about the anatomy at all. So when I was in the clinic, the patient will come to me, they will say, I feel dizzy. And I was like, uh-oh, okay, you did not eat. They said, no, I had my breakfast. They'll say, no, it was not enough. You need to go back home, eat enough and come again. So they will go back home, come the next day, and I start do their exercise, and then they will throw up at me. And I was like, uh-oh, you came too early. You should pick this time between you eat and you digest, then you come to me. So the patient did the same thing. They went back home, they waited a little longer, and they came back and they still saying, I feel dizzy. So I was like, okay, maybe you are so much stress. I need to refer you to psychology. She went to the psychology. She got her anxiety medication. She felt more dizzy because of my anxiety medication. She fell down. She hurt her hip. And all of that is caused by me because I did not know that I could treat people who are dizzy. So I would like to apologize for that patient in 2010. I'm sorry about that. I didn't know. When they told me you could treat people with dizziness, I would say, what I'm gonna do? Don't be dizzy. Move your head to not feel dizzy, but you are already dizzy. So I hope by the end of this lecture, at least one of you, when you get a patient who come to you and they say, we are dizzy, to look from them from a different perspective and say, I might help you. You are in the right place. So I like to start with this slide, which is the revolving door, which is always my advice. If you're gonna start a business for treating people who are dizzy, never, ever having a revolving door at your entrance, or you will see this. Okay, so today we'll talk about vestibular rehabilitation. What is vestibular rehabilitation? And how does it work? And does it actually work? We will see. So I will go a little bit about just define what is vestibular rehabilitation for people who doesn't have any background. How common are they? A brief anatomy and physiology, symptoms and terms that you need to know, some causes, how to evaluate them and assess them, most common type of vestibular disorder, and what type of exercise are involved in therapy. So what is vestibular rehabilitation? Vestibular rehabilitation is actually physical therapy. It's an evidence-based approach of physical therapy that you can use to treat dizziness, vertigo, motion sensitivity, not just that, also balance, posture control issue, and that occur due to vestibular disorder. So how common are they? Unfortunately, they are really very common because it affects any age, from children to older adult. So, and unfortunately, children frequently miss the screening and don't receive the medical care because they don't know what to say. They cannot say I'm dizzy. You say I'm tired. You will just see your child will be clumsy. Approximately 35% of Americans report a lifetime prevalence of dizziness. And we were lucky enough to be able to conduct a study here in Saudi Arabia, and we found out that it's 43% of Saudi Arabia who have experienced dizziness at least once in their life. So what is the vestibular system? There is a misconception that vestibular system is just about the ear. No, we are saying a system, not the apparatus. So the system includes three parts: the vestibular apparatus of the inner ear and the eyes and the area of the brain. So we have signal from our ear, we have signal from our eyes, and we are translating that with our brain to understand what's going on. And your vestibular system is your body GPS system. And this is what I mean by that. So you are on a train. You are excited because the train is going to move and start moving. Take a final look at the people outside. Finally, we have moved. Looks good. And you find out you are not that is moving. It was the other train. So this is what vestibular system do. So you look, you use your vision, you see the train is moving, but does you really moving? No. So this is what the vestibular system telling you. I'm seeing this train is moving, but my body, my vestibular system is telling me, no, I'm sitting still. I'm not moving. So this is how it's worked as your GPS system. So and now we will talk about the peripheral vestibular system, the outer part, because this is mostly what we deal with. So there is two parts. There is this part out with 3 canals, superior, posterior, horizontal, semicircular canal, and those are related to angular acceleration, not gravity sensitive. And we have 2 parts here, the otolith, which is utricle, saccule, which is related to linear acceleration, and they are sensitive to gravity. And the vestibular ganglia and vestibular nerve. Here's another look that makes it easy. So this is the labyrinthine. This is where we have the saccule and utricle, and this is we have the other part of the vestibular system, which is the hearing organ, the cochlea. So hearing actually for higher frequency motion, which is sounds. Vestibular organ, it's for low frequency motion, which is movement of your body. So now the labyrinthine. So this is the labyrinthine. So the labyrinthine is filled with fluid. Okay. So imagine you have a cup of water that's filled to the top. If you move to the side, there will be drip. The water will move, drip off. If you move up, the water will drip because it's filled to the top. So this is what happened with the labyrinthine. We have saccule and utricle, and those are responsible for the linear movement. I'm moving forward, backward, I'm moving side to side, but it will not tell me if I'm moving forward or tilting forward. That's why we have the supporting system with the 3 canals, which is responsible for the angular rotation of the movement. They will tell us, I'm turning to the right, I'm turning to the left, I'm tilting forward, I'm tilting backward. So I'm not gonna go so deep because I don't want you to hit vestibular, but just like a quick look. So I'm not sure if you can see my arrow, but this is the otoconia. It's like a solid piece at the top where the fluid is down, and there is something called kinocelia, the longest one, like the atina, and there is the hair cells. You can see it here and here, but I will explain on this one. So when you are moving forward, so this is, it's here in the 3 circular canal. It's also present at the saccule and utricle. So it's responsible for the movement. This is how we sense movement with the excitation and inhibition. So if you have the retina in your car and you're moving forward, the retina will go to the back. So that will go toward the hairs. They press them to the back. And in this case, you will have the acceleration. It will be translated, the excitation. Okay, now we are accelerating. And then they are elastic, so it will be constant. And you will go to the front. When it's going to the front, here we have the deceleration. That's mean we are slowing down, and there will be the inhibition. Let's go to the next one. Okay. So here's another picture that I like about the hair cells, how they are really organized in the saccule and utricle. And you see it here again. For the utricle, it's for lateral, side to side. So they are moving side to side. I'm moving to the right, I'm moving to the left, excitation, inhibition. And the saccule, it's like the elevator going upward, backward. So if I'm moving upward, I have the excitation. It's telling me I'm moving forward. No, right now I'm going down. So I think that's enough with anatomy. So why do we need to know this information? Why? What its benefit of it to us? So labyrinthine, it tells us. So for example, you are moving this way and you are not reading where are you going to. You're closing your eyes. It will fall off. So you need this system. So I'm moving this way. Okay, hold on. Go back to yourself. We are an inverted pendulum model. So we have this space. We move this way. If we didn't get the information, we wouldn't have the agility to step to the side, to the back, front, to the back, to help to correct our balance. So function. We already know that we have it for gaze stabilization, posture stability, orientation space. What about dysfunction of the vestibular system? We will feel dizzy, we will feel nausea, oscillopsia, abnormal gait, positive vestibular finding. But there is one point I really need to emphasize on. Not always dizziness. Because if you have like a loss of function this ear, you have information this ear, you will feel dizzy. But what if you have lost the function in both ears? You will not feel dizzy, you will not get nystagmus, but still you have vestibular loss. So this is something we need to focus on. So some people say, I'm treating vestibular people, I treat dizzy people, but people who with vestibular disorder, not always dizzy. There is people who have lost their vestibular system. So they don't get dizzy, they don't get nystagmus, but they have the sensory dysfunction. They have function loss, like people with bilateral vestibular loss, and also people who are aging. Sometimes they have a decline in their vestibular system. What I mean by sensory dysfunction, I will show you how do they see the world. So this is how they see the world. They don't have stabilization. They are moving, but nothing is telling them that they are moving. They use their vision, so their vision is not stabilized. It's like a camera without stabilization. So this is how they see the world. This is the oscillopsia. I'll talk about it a little bit. So this is awful. This is hard to keep their balance. They have lost the function of the vestibular system, but they don't get dizzy. Okay. So I keep saying dizziness, dizzy, dizziness, dizzy. And maybe some of you know it is dizzy, but let's talk about it in more formal definition. It's a non-specific term often used to patient to describe symptoms. So make sure that it is symptoms. The most common disorder lumped under this term include vertigo, non-specific dizziness, disequilibrium, pre-syncope. So there's a lot of term under the dizziness. Dizziness is a big word. So I will emphasize on this. Dizziness is a symptoms, is not a diagnosis. Is not a diagnosis that's interrogation with. Could you please mute your mic? Could you please mute your mic? So, terms and definition. So I will have to define some terms. Nystagmus. So nystagmus is an involuntary rhythmic side to side, up and down. So it's movement of the eye. So it will move side to side or up and down or some circular motion that occur with a variety of condition, different tests. Otoconia, the one that I show you with the utricle, saccurant, also in semicircular canal. They are small crystals of calcium carbonated in sacral and utricle, and they are hauled to the fluid. How they are getting back stuck to the fluid, no one know yet. So here the nystagmus. More terms. Oscillopsia. It's like the video I show you with the whole world is moving, is unstable. So it's the illusion of unstable visual field. Tinnitus, the hearing noises that are not caused by sound outside. It's actually caused by sound that from inside. Ear fullness, sensation of blockage in the ear, like you are in the airplane and there it's landing. You know that pressure you get in your ears? It's the same thing. Or if you are driving up a high mountain. So some facts again. So now you might say, okay, they have dizziness. Okay, they don't have dizziness. They are unstable. They are people with vestibular disorder. Vestibular disorder are not easy to diagnose. You need to keep this in your mind. If you keep this in your mind, you will be able to diagnose it. Because, based on the fact, on average, patient visit 4 to 5 doctors before receiving the right diagnosis. And most patients spend 3 to 5 years before receiving the appropriate care. Even some of them spend more. I have a patient who spent 10 years then until she was able to meet me to be diagnosed with vestibular migraine. So not all dizziness is vestibular. Not anyone walk to your clinic, say I'm dizzy, you say, okay, you are a vestibular patient. No, it can be caused by medication. So you need to take a good history, rule out other condition. It could be due to medication. It could be due to postural hypertension, which I thought it's for all the dizzy patients in 2010. It could be due to diabetes. It could be due to thyroid condition. It could be due to renal failure. It could be due to transient ischemic attack, which is dangerous. So here's some typical peripheral signs and symptoms you might see with people who come in with vestibular disorder. So they might come and say, I feel dizzy with positional changes. So when I go out of bed, I feel dizzy. When I roll in the bed, I feel dizzy. When I look to my right, I feel dizzy. There may be hearing loss in some condition. There may be tinnitus that associated at the same time with dizziness that tell us there is some condition. There may be or may not have balance problem. They may be really good in compensating their vestibular hypofunction and they don't have any balance problem. They often have symptoms with head movement during gait. And during acute phase, nystagmus will be seen. Sometimes it will be seen while they are sitting, just moving their head to the right and left. But with the chronically, the system is so smart. So they could compensate, and nystagmus would be seen only in like with some tests, and sometimes will be really mild. You won't be able to pick it up, or they will be able to compensate for that nystagmus. May have vertigo associated with positional change, as we say, and may have oscillopsia, which they come and they will tell you, they will not tell you we have oscillopsia. They will come in and say, I feel like the world is jumping. I turn to the corner, the world is jumping. I drive my car, the world is jumping. So, and this is really the upper layer we get. Those people will come with cognitive impact like a foggy brain because of what they have experienced. Psychological impact, they feel depressed, they feel anxiety, they are fatigued, they are tired. They have diminished their quality of life and they will start talking, I used to do this, and now I can't do anything. So this is like the layer at the top. If you look at it, you dig deep, you ask about the question of the dizziness, and then you'll dig deep. Dizziness, because we said it's not a diagnosis. You find their disorder. So you should not ignore this. So how common are those disorders? For example, to start with, benign paroxysmal positional vertigo. I will talk about it also. It's very common. It's very common. It will be not even one day that pass in the clinic without receiving one or two, between 2 days. Meniere's disease, it's also common. And bilateral vestibulopathy. I didn't see much, maybe in whole my career, maybe I just saw one or two. Perilimb fistula, rare and hard to pick up. Labyrinthine concussion, uncommon. Neuritis, very common. And labyrinthitis, it's also common. So the evaluation process of this patient. So the evaluation process for patient with dizziness consists of history. It's the golden key. History, vestibular bedside exams, laboratory testing. So you start with the history. Like you will start asking, okay, based on that history, you will decide which vestibular bedside exam. You are not going to do all the bedside exam. Based on your history, you will decide. So history is the key. And I always say, if you patient come to you and ask, do you ask them, what do you feel? Do you feel dizzy? Are you staggered, like you're off balance? And they say, yes. Be more precise, this or this. Okay, if they didn't answer between one of them, they're balance off or they are dizzy. That may be not your patient. So, and also as a physical therapist, you should ask this question most importantly by the end of the session. What is that one thing you want me to fix today? You are sitting there, tell your patient you are sitting there, tell me just one thing, not 5 things, not 3 things, one thing you want me to fix today. Based on that answer, you will be able to figure out what's wrong with your patient. So how to evaluate the patient? So if they said you are dizzy, you will ask them, what do you mean by dizzy? They will say, I'm dizzy. So like, could you tell me how do you feel dizzy? They will say, I told you I'm dizzy. When? They will say, all the time. This is the answer you will get. So you have to dig deep and be smart by asking. So start asking about the onset. When did it start? Did it start all of a sudden? There was like a previous event that before it started? Okay, describe your dizziness. And then give them some option like, do you feel like you are spinning and the world is still? Do you feel the world is spinning and you are still? Do you feel like you are in a boat? Do you feel the world is jumping? And then you go on from there. If they said, okay, you had the answer, what is the duration? Does it last more than a minute or less than a minute? If it's less than a minute, it could be BBV. If not, there may be other condition. What is the associated symptoms? As we said, if there is tinnitus, okay, that's give me a hint for some condition. It's provoked by something. For example, do you feel more dizzy when you roll in the bed? Or do you feel dizzy when you go to the mall that's empty? Do you feel dizzy when you are outside where there is a lot of people, crowded places? Or is it when there is lights, a lot of lights on? Every answer, it's really direct you to diagnosis. And always check for head and eye alignment to make sure is there nothing central, and ask for any comorbidity that might causing dizziness imbalance, like peripheral neuropathy. So here is a chart. You could take like a picture of it because it's really good and helpful and have it in your clinic. They'll talk about like different type of dizziness. You have the vertigo, you have the disequilibrium, you have the breathing, lightheadedness, and from there you go on, like ask about migraine symptoms. Do they get dizzy with the high sounds, lights? No. Yes. Do they get aura? Yes. No. There is hearing loss. Yes, that's mean episodic vertigo. No, also episodic vertigo, but yes, BBV, no vestibular neuritis. So this is really helpful chart you could hang in your clinic. So what did I say? I said why I asked about the duration, but let's get some example. For example, if their symptoms last from seconds, that's mean they could less than a minute, could be BBV, could be vestibular migraine, could be vestibular paroxysmia, minutes, vestibular circulation, transit ischemic attack, vestibular migraine, hours. It's that guide us to maybe vestibular migraine, Meniere's disease, more than 24 hours. Vestibular neuritis, posterior circulation stroke, and again, vestibular migraine. If you take a look, there is vestibular migraine all of the duration, but it's really, you will be able to pick it if you ask about, not the headache, because sometimes it comes without the headache, but you will be able to pick it if you ask about the aggravated factors, like the sound, photophobia, phonophobia. So associated symptoms. In ICA infarction, like acute unilateral tinnitus and hearing loss, acute. Like I said, that means that ICA it's central. It's not like something you could treat in your clinic. Meniere's disease. You will have symptoms of airfulness, tinnitus, fluctuating of hearing loss with vertigo lasting hours. And sometimes they will not be able to pick up the hearing loss because it affects the low frequency. Vestibular migraine, vertigo, migraine headache, not always, phonophobia, photophobia, visual aura. And breast infarction, demyelination, neurological symptoms, diplopia, we know the 5Ds, diplopia, facial paresthesia, weakness, dysarthria, dysphonia, that's mean it's central. So you could be smart and find some recent event, as I said before, it could give you a clue, like what happened, if there is anything major happened before you feel dizzy, hit trauma. Okay, the trauma that's mean could cause BBV, could be skull base fracture, lymphatic fistula, migraine, or concussion. Change in blood pressure medication. Okay, maybe they are having a posture hypotension. So, and the onset is the spontaneous or trigger. So spontaneous usually will be vestibular migraine, but also it's triggered. So vestibular migraine is a really complicated condition. Meniere's disease, posterior tract circulation, vestibular neuritis, but triggered BBV when you move your head in relation to your body. Vestibular migraine is also happening with the movement. Central positional vertigo also related to the movement. So it will be triggered by something. So what is BBV that I talk about a lot? So BBV benign, that is not a life-threatening, which I don't agree with it because it could be life-threatening. Some of the people who fell off during the episode of vertigo get hurt themselves. So paroxysmal sudden attack, positional, it's with a specific head motion, not the whole body, head motion in relation to the body, and vertigo, which is the incorrect sense of rotational movement. Types of BBV based on the affected canal. So there is the posterior canal. So each canal you will be able to tell which canal by the movement of the eyes. So For the posterior canal, it will be upbeating torsional. For the lateral canal, side to side. For the anterior canal will be downbeating. So it's different. It's really a large topic. It be treated by the every maneuver. There is so many maneuver. Each year there is 2 new maneuver for treating BBV, and I won't be able to cover it in this lecture because it need a whole lecture for the BBV. So symptoms. Symptoms also, as I said, last less than a minute, provoked by changing head position, provoked by bending over, rolling. This is sometimes they might tell you that. I bend over to pick something. I look up to the clock. I roll in the bed and I feel dizzy. No ear pain, no tinnitus, no hearing loss. There is a outcome measure that's called dizziness handicap infantry. If you could write it down, just write it down because this is something you should use always. There is 2 items of this outcome measure. It's really measure the BBV. 2 questions. Dizziness with getting out of bed, dizziness with rolling in bed. If people answer by this by yes, they are 4.3 times most probably having BBV. So there is a questionnaire that could help you if you are not so much good with the eye movement. While the pre-test probability of BBV is 22.5%, actually after this test increase the probability to 43% before any other test is performed. So this is really a nice information. Meniere's disease. Here's the second disease that I said it's really common. Meniere's disease is a disease of the inner ear that is caused by viral infection, abnormal immune response, abnormal nature of ear, migraine, and head trauma. But we need to know how can we recognize this Meniere's disease. First, air pressure, fullness. They will come with these symptoms. It's like a textbook. And I will talk some bits laboratory test. It will not show if it's in early stage, but this is like textbook symptoms. Air fullness, tinnitus, transit vertigo that lasts from 20 minutes to 24 hours. Fluctuating low, if you have the audiogram, you will find the fluctuating low frequency hearing loss that might end up with a permanent hearing loss. The vertigo is accompanied by nausea and vomiting. Again, as I said, migraine is really complicated disease that's overcome with a lot of vestibular disease disorder. So here's a table that shows the difference between them. Okay, vestibular neuritis, which is really common. So it's the most common, the second most common cause of peripheral vestibular vertigo. It occurs as a result of inflammation or infection of the nerve, commonly due to bacteria. So usually when people who come with vestibular neuritis, you will ask him, did you get sick like in a couple 2 weeks? You said, yeah, I had a flu, I was so sick, I knocked down, I was laying in bed and all of that, and then I have this vertigo. So this is really a big hint for you that they might have vestibular neuritis. Often it's preceded by, as I said, with the present viral infection by as long as 2 weeks. Okay, so what are the symptoms? Sometimes they have the oscillopsia as well. They will say, so they have the oscillopsia, but their complaint will be like, I have difficulty with my vision. I have this gait instability. But this is the symptom they have: the oscillopsia, vertigo, posture imbalance, nausea, vomiting sometimes when it's in their acute phase, but no hearing loss at all. Spontaneous horizontal rotatory nystagmus. You will see it if you have to do the test. And those symptoms, they will say, I really feel dizzy, or like my vision is difficult for me when I move my head fast. I turn my head fast to the right, to the left, down and up. I feel really dizzy and uncomfortable. This is also a sign for vestibular neuritis. Labyrinthitis, we said also it's common. So this one is occurred due to inflammation or infection of the inner ear, commonly due to bacteria. Symptoms, again, pretty much the same. But there is one thing that's make it different: the hearing loss, because it's affecting the nerve. So the hearing loss and the tinnitus that will not present with the neuritis. So you are so happy to welcome the dizzy patient to your clinic, but you need to be also cautious not to hurt those people. So you should know and recognize when you should refer back to the physician. This is one important thing. You don't say I could treat anyone with dizziness. No, we are a team. You should be when, okay, this is time, it's about my patient. I have to think about the safety of my patient. before anything else. So if they have a downbeating, there is a downbeating, we said, with the canal BBV, but usually it's central because it's rare to be seen. Upper motor neuron signs, which you all know about, the positive Papinski, the clonus, the increase in deep internal reflexes. They may have cerebellar signs and symptoms with the coordination. They have swallowing difficulty, change in sensation that are not explained by premorbid impairments like the diabetes. Change in papillary size. You have one people big and the other one small. Orbitosis. This is not something you could control or handle or manage. Loss of conscious, of course, repeated unexplained serious falls. So here's some other symptoms. Patient reports sensation of being pushed off balance, like someone is pushing them to the side. This is really a sign of brainstem transit ischemic attack. Fluctuating hearing loss, visual field loss, memory loss, unilateral hearing loss. So if the patient have any of the above sign and symptoms, it's central. It's urgent that you send the patient to the physician or ER to be saved. So here's some typical central vestibular disorder, but I will not talk about them. I'll just mention them. Stroke, it's uncommon, except in the case of the anterior inferior cerebellar artery, ICA and BICA. Multiple sclerosis, it's really common. Migraine dizziness, this is like, if you dig deep into migraine dizziness and you start see patient, you will find maybe 2 or 3 in your clinic every day. They have migraine dizziness, especially with the stress. Head injury, cervicogenic, it's uncommon. So what type of exercise are involved? There's a lot variety of exercise. I will talk about the few things that I really just want to open your eyes on some topics, but I can't cover everything. So depending on the vestibular related problem, this is what you think about. It's about the related problem, identified and related symptoms. There's a 3 principal method of exercise. Habituation, from its name, gas stabilization, and balance training. So habituation exercise, it's to expose them to what make them dizzy to make them good. So there is 2 types, self-motion to make them move. For example, I feel dizzy whenever I pick something from down and they don't have BBP or other things that we could manage. For example, motion sensitivity. So I will start doing for them the same exercise, pick something and put it up. Slowly pick something and put it up. Then I put some background, difficult background. Okay, pick something and put up with a difficult background. Okay, I have the disco ball again. Then I have some other external disturbance to increase them. So this is like self-motion. Visual stimuli. For example, they are dizzy whenever they go to shopping mall, grocery store, watching TV, walking often. Pattern surface. So I will start to expose them to this environment in a graded way to make them, to desensitize them from this. For example, I give them a YouTube video and watch this, like someone is driving the car because they feel dizzy. Watch it at lower speed, watch it more, increase the duration, add some noise background, remove it, add some sounds, and so on. Not for dizziness symptoms, as I said, that are spontaneous in nature. And goal, it's to reduce dizziness through repeated exposure. But provoke the patient dizziness. But about the intensity, no one knows yet. How can you set the intensity for your treatment? Unfortunately, we don't know yet. How to start your intensity, to choose it, to pick it up, we don't know. You have to start from your patient the first session to sit them and see which exposure that doesn't make them sick after the finish. If they get sick for more than 20 minutes after they finish their exercise, this is wrong. You need to lower the intensity and so on. So over time and good compliance and perceiving, the intensity of dizziness will decrease. Really, it's like a chart with, like, you reach this at this level. If you reach this level, you will get sick. Explain that to them. You get sick. You get this level, you will feel better then after that. So you have to cope with it, but not in a way that make them really sick. And the dosage, as I said, we don't know yet. Gas stabilizing exercise. So when they have difficulty with their vision, designed to improve the coordination of eye and head movement. So it's appropriate if the patient experience problems seeing clearly because of visual fear. There is no gaze stability, and they appear to bounce or unstable or jump around. And it's a different type. There is a VUR, something called with one target. So you have one target, you look at one target, move your head. There is another one which you move the target, and you move the target, your eye, then move your head, go back, look at the target, move your head. There is a different one which is remember target. You put the target, you remember it, close your eyes, go back, keep your eyes on the target, and open your eyes, still looking at the target. So there is a different type of gaze stabilization exercise. So type of exercise. The first type, as I said, the one that's with the head movement. I explained this before I reach the slide, but you can improve this again with including the movement. For example, they look at the target, moving their head. They were still. Now I ask them, they were sitting. I ask them to stand. From standing, I ask them to step backward, step forward, add some noise in the background, add some disruption from the environment, and so on. Balance training exercise. People who don't get dizzy, we need also to train them for their balance training exercise. So it's designed to improve balance. So the daily activity of self-care, which is our goal, their quality of life. This should be your goal. Work and leisure can be performed. So we will help them do standing, bending, reaching, turning, walking, running, walking outside, and sharing the community. So make sure of the following in the exercise. These should be challenging, but safe enough so the patient do not fall. And there is one thing I always say to patient with vestibular disorder: the wall is your friend. If you give him exercise, ask him to be next to the wall, or they have a wall behind their back, or choose a safe corner. So we could challenge that by adding visual somatosensory cue. We could, from stationary position, movement while doing the exercise, coordinated movement. They could do dual task. For example, hold the cup and go get something and come back, or hold the cup and do the remember target. You could be creative. Again, keep in mind, at first, as I said, exercise might be symptoms. Symptoms seem worse, so you need to explain this to your patient. You will feel sick. I will make you sick. You will hate me. You will say I will never come back again, but believe me, after 4 or 5 sessions, you will come and thank me for that. Symptoms should steadily decrease, and participation in daily life will be easier for them. So this is take-home message for you. Dizziness is a symptom, is not a diagnosis. Don't send someone with a diagnosis of dizziness. History taking is the golden key. Listen to your patient. Your patient doesn't lie. Listen to your patient. Explain to them why they feel dizzy. What are you doing to them? Challenge them, but start with less. Make sure they are safe. If symptoms after vestibular rehabilitation therapy last more than 20 minutes, decrease the intensity. This is wrong. This is above their limit. Teach your patient how to avoid handle trigger. Tell them if this will be your trigger with this condition. You need to avoid that at least now until we start treatment. If there is a wall, touch the wall. If you feel dizzy, put your finger on anything to feel stable until your brain that you are not moving. And at the end, it's about the patient goal, not your goal. It's about what they want to achieve, not you want to achieve. And thank you.
Thank you, ma'am. Now we are open to take queries from the participants. Respected participants, please drop your queries in the chat box. Participants may drop their queries. Ma'am, there's a question how to convince patient to perform habituation exercises. Okay.
Okay, what was the question? Thank you. What was the question?
First, how to convince the patient to perform habituation exercises.
It's not about convincing the patient, but if you explain to the patient, for example, you did the test in your clinic and they are turning forward and they feel dizzy, and you ask them, okay, so this position make you feel dizzy. This is because of this and this based on their condition. Okay, so what is going on? Explain to them. Explain to them. So if you do this again for the you will do this, it will make you dizzy. After a while, it will make you less dizzy till you feel normal. So you have to explain to them. If you don't explain to them what's wrong with them, explain to them how the vestibular system is working. So all the system, if you do this for them, you will make them feel worse, except the vestibular nucleus. If you do this to the vestibular nucleus, it will get adapted to this trigger. So it's work in a different direction. So if they explain this to the patient, show them picture. It's okay, spend time with your patient. Show them the picture, explain to them. So this is what happened. This is what happened in your system. This is what we are trying to get. They will understand. No one doesn't want to feel good by the end of the day.
Thank you, ma'am. There's another question in the chat box. Brief us up with Halpike maneuver.
Dexhal bike. Okay. So that's for treating the BBVV. And as I said, this is really a large topic. The Dexhal bike is a test to test the BBVV to find out which canal is affected and if it's positive for BBVV. For the treatment, we could use EBLI. There is a trillion. Really, there is a lot of maneuver. I can't cover this in lecture 4 introduction. Usually, they will do a whole lecture for BBVV. But if you look online, we'll find a lot about that. But to be covered, it's need a whole lecture by itself.
Okay, ma'am. How can we help a patient with a head injury who is complaining of vertigo?
With complaint for vertigo. So head injury, it's an event that's happening, but it depends what happened because of the head injury. Is it concussion? Is it a fracture in the skull? Is it BBVV? Because head injury sometimes move the crystal and cause the BBV. And if that is the case, I will do the Ebley maneuver and they will be fine. If it's not, if it's a concussion, that will be a different rehabilitation program based on the test that we do. And based on that, we find out which movement exaggerate their symptoms and we treat that. Any other question?
Thank you, ma'am.
Thank
Ma'am,
you.
there's another question in the chat box. Would you like to have a session on Dexhalpike maneuver?
As I said, it's need to be a whole different lecture. And there is some people, there is a therapist who is really good with BBV. I could recommend.
Participants, kindly fill that feedback form. Ma'am, there's a question. I read the vestibular therapy is used with traumatic brain injury, not only for vestibular disorder. Do you have idea if?
Yeah. So traumatic, it's for the concussion, as I mentioned. So concussion, because of this strong force from outside on the head, it caused this disruption of the system. And as we said, vestibular system, it's not just about the ear. And again, BBV could be caused by traumatic head injury. Any other question?
Mom, you talked about somatosensory cues, things we should take care of. We can help the patient. Mom, what are those somatosensory cues like visual cues? So those LED lights and jackets fitted with those LED lights, and we can put marks on the floor where the patient can get the idea where to move on, where to put the next step. Mom, what about somatosensory cues?
So somatosensory cues, we could do something for challenging. For example, they do the test while they are standing on the solid floor. There is nothing. We are not the somatosensory, right? They have the right signals. But if we put them in the foam, that will challenge their somatosensory. So you have to play with the sensation. Okay. Any other question? Or thank you so much for all your time. I hope you have learned something and have a great day, everyone. Thank you.
Okay. Big thanks to you, Dr. Doama, for her gracious presence and sharing her illuminative knowledge from years of experience. Please accept gratitude and appreciation from the BCIP family for the way you fulfill the position of supervisor so diligently. It was an insightful evening. Thank you, ma'am, for the much needed interaction. Thank you, spectators. Kindly fill the feedback form in the chat box.
Dear all, kindly fill the feedback form shared in the chat box.